It is 2:47 in the morning, and a woman named Sandra is sitting in a plastic chair in the emergency department of a mid-sized hospital in Ohio. She has been here for 3 hours. She came in with chest pain, the real kind, the squeezing around the ribs kind that made her pull her car over on the highway. She is 53 years old. She is self-employed, and she has a high-deductible health plan that she picked because it was the one she could afford. A nurse took her vitals 90 minutes ago. A doctor appeared briefly, ordered an EKG and a troponin panel. And now, Sandra waits, on a gurney in a hallway, because every room in the department is full. She does not know yet what her bill will be. She will find out in about 3 weeks, when a statement arrives in the mail. And when she reads it, she will not understand it. The line items, the facility fees, the separate charges from a physician group she has never heard of, the codes that map to nothing in plain English. She will call the billing department. She will be placed on hold. This is the American emergency room, a system built on contradictions, a mandate without money, a safety net that charges you to fall into it, and underneath the confusion of your bill, a machinery of incentives that was decades in the making. It starts with a single law. And like most things that go wrong slowly, it started with good intentions. In 1985, the story was undeniable. Hospitals across the country were doing something they called patient dumping. A woman in labor, uninsured, would arrive at a private hospital and be turned away at the door. An accident victim without an insurance card would be loaded back into an ambulance and driven past 2 closer hospitals to the county facility. People were dying in parking lots. An investigation by the Inspector General of the Department of Health and Human Services documented 250 cases of patient dumping in a single year in Chicago alone. Congress acted. In 1986, tucked into an omnibus budget bill, the Emergency Medical Treatment and Active Labor Act, EMTALA, became law. The rule was simple. Any hospital that accepted Medicare payments, which was essentially every hospital in America, was required to provide a medical screening examination to anyone who walked through the emergency department doors, regardless of their ability to pay. If a patient had an emergency medical condition, the hospital had to stabilize them before transferring or discharging them. No exceptions. No turning people away. The law was morally necessary. People had been left to die at the curb. Something had to be done. That is the honest truth of EMTALA, and it should be stated plainly before we go any further. But Congress did something notable when it passed the law. It imposed the mandate and declined to fund it. There was no appropriation attached to EMTALA, no reimbursement mechanism, no federal dollars earmarked to cover the cost of care that hospitals were now legally required to provide. Hospitals were ordered to treat and then left to figure out how to pay for it. That single decision would shape everything that followed, every billing practice, every facility fee, every private equity calculation, every closed rural hospital. The law created an obligation. It just didn't create the money to meet it. The math of an unfunded mandate is uncomfortable arithmetic. When a hospital treats a patient who cannot pay, that cost does not disappear. It gets redistributed. Hospitals recover uncompensated emergency care costs by charging higher prices to the patients who can pay, specifically to insured patients and to private insurers. The uninsured patient who receives $3,000 in emergency care and pays nothing is, in a very real sense, being subsidized by the privately insured patient in the next room, whose insurer is billed at a rate inflated to cover that shortfall. This is called cross-subsidization, and it is the economic foundation on which the American ER has operated since 1986. The numbers are significant. The American Hospital Association reported that from 2000 through recent years, hospitals collectively provided more than $745 billion in uncompensated care. The annual direct cost to emergency physicians from uncompensated care mandated by EMTALA alone has been estimated at $4.2 billion. And federal support through Medicaid disproportionate share payments and other mechanisms covers roughly 80% of that gap, leaving billions in costs that must be recovered elsewhere. That elsewhere is your bill. The machine has another gear, and here is where it gets more interesting. Hospitals found a way to survive the EMTALA mandate. They built profitable service lines to cross-subsidize unprofitable ones. A hospital that performs a high volume of elective orthopedic surgeries, knee replacements, hip replacements, can use the margins from those procedures to offset the losses from emergency care. Academic research found that orthopedic procedures generated average margins of around 22%, while emergency conditions consistently generated negative margins requiring that external subsidy. The system works, in other words, as long as the profitable procedures keep flowing. That created an incentive that may surprise you. Hospitals have a structural reason to prioritize services that attract commercially insured, elective patients. The knee replacement, the cardiac catheterization, the scheduled procedure that generates predictable revenue, over services that attract uncompensated or undercompensated emergency patients. The ER keeps the lights on morally and legally. The surgical suite keeps the lights on financially. We will come back to why that tension matters. But first, the staffing companies. In the early 2000s, a quiet transformation began in how American hospitals staffed their ER departments. Physicians had traditionally organized themselves into small independent groups, contracting directly with hospitals to cover shifts. That model began to give way to something different: large physician staffing companies that could take over the management of an entire department, handle scheduling, billing, and administration, and offer hospitals the convenience of a single vendor for all their ER physician needs. Two companies came to dominate this space: Team Health, owned by the private equity firm Blackstone, which paid $6.1 billion for it in 2016, and Envision Healthcare, specifically its M-Care division, which was acquired by KKR in a take-private deal worth $9.9 billion in 2018. Together, these two firms grew to manage tens of thousands of emergency medicine physicians across hundreds of hospitals nationwide. Private equity ownership of companies follows a predictable logic. You acquire a business, often with significant debt. You improve margins. You grow revenue. You exit at a profit. The challenge with physician staffing is that margins in emergency medicine are constrained, at least if you are billing at rates that patients and insurers find acceptable. So the private equity-owned staffing companies found a different lever to pull. They went out of network. When a physician group is in network with an insurer, the group has agreed to accept the insurer's contracted rates. When it goes out of network, it can bill at whatever rate it chooses. The patient's insurer pays a portion, and the physician group bills the patient directly for the balance, a practice known as balance billing or surprise billing. A Yale University team of health economists studied what happened when M-Care took over the management of emergency departments. The findings were striking. When M-Care entered a hospital, it nearly doubled its charges for caring for patients compared to what the previous physician groups had billed. Team Health's internal documents, later scrutinized in congressional testimony, described surprise billing not as an unfortunate billing error, but as a deliberate strategy, a source of, in their own words, contracting negotiating leverage. The logic was cynical and precise. By staying out of network, they could demand higher payments from insurers under the threat of continued balance billing. Insurers eventually capitulated, paying rates far above what independent physician groups had accepted. The difference flowed to investors. You were the leverage. Your $300 ER copay landed in your mailbox weeks after your visit, followed by a separate bill from a physician group you had never heard of, charging you the balance between what they billed and what your insurance paid. Some of those bills ran to thousands of dollars, and because you had no way of knowing, when you signed in at the emergency department in the middle of the night, that the doctor about to treat you was employed by an out-of-network staffing company operating inside an in-network hospital, there was nothing you could have done differently. We will come back to how that ended. But first, there is the fee you may not have noticed. Look at an ER bill carefully, and most people do not, because the formatting is deliberately opaque, and you will find a line item that does not correspond to any specific service you received. It may be labeled Emergency Department Facility Fee. It may be labeled Facility Service. Whatever it is called, it is the charge for walking through the door, for existing inside the building. It is separate from the physician's fee, separate from any lab work, separate from the X-ray, the CT scan, the IV medications, the tetanus shot. Those all appear on their own lines. The facility fee is the cover charge. A Peterson K. FF analysis of facility fees found that for a moderate acuity level 3 visit, the kind of visit that accounts for a large share of ER utilization, the facility fee alone has a median of roughly $412, but ranges from just over $100 to nearly $7,000 depending on the hospital. For a high acuity level 5 visit, the median facility fee approaches $1,000, and facility fees, according to that same analysis, can account for up to 80% of the total cost of an ER visit once all the other charges are added in. The legal basis for the facility fee is real. Hospitals are allowed to charge it because the Centers for Medicare and Medicaid Services permit emergency departments, as hospital outpatient departments, to bill separately for facility costs, the building, the nursing staff, the overhead of maintaining a 24/7 operation. The argument for it is not irrational. An ER that must be staffed and equipped at all hours, that cannot turn patients away, that maintains trauma bays and crash carts and isolation rooms that may sit empty for hours, has genuine fixed costs that a physician visit alone does not cover. Someone has to pay for the readiness. But here is the problem. There is no standardized national cap on facility fees. There is no requirement that the fee be disclosed to you before you receive care. You will not know what your facility fee is until the bill arrives. And the variation in what hospitals charge is so wide, from $100 to $17,000 for the same level of visit, that the fee has drifted from a cost recovery mechanism into something more like price setting, with no competitive market to discipline it. By the time you add the facility fee to the physician fee, to the lab fees, to the imaging fees, the average ER visit costs the uninsured patient somewhere between $2,500 and $3,000. For the roughly 25% of visits that are the most severe, that figure climbs past $3,000. And even if you have insurance, you are not necessarily protected. The average out-of-pocket cost for an insured ER visit runs around $650, and that is before the separate bill from the physician group, which may arrive weeks later and may not be in your network at all. Now the beds, or more precisely, the absence of them. Walk into almost any major urban emergency department in America, and you will find a scene that has become so common it is no longer remarked upon. Patients on gurneys in hallways, patients waiting in chairs for rooms that will not free up for hours, patients who have been seen, diagnosed, admitted to the hospital, meaning a physician has decided they need inpatient care, who are nevertheless still physically in the emergency department, sometimes 12 hours later, sometimes 24, sometimes longer, because there is no inpatient bed available. This is called boarding, and it is the defining operational crisis of the modern American emergency department. The scale of it is difficult to absorb. A 2024 University of Michigan analysis found that during peak winter months in recent years, nearly 5% of all patients admitted to hospitals from their emergency departments waited a full day, 24 hours, for a bed. In January 2022, 40% of admitted patients boarded in the emergency department for more than 4 hours. The Agency for Healthcare Research and Quality convened a formal summit on the boarding crisis in late 2024, calling it a national public health emergency. What boarding does to an emergency department is compound every problem the department already has. When a third of the beds in an emergency department are occupied by admitted patients waiting for inpatient rooms, that is a third of the department's capacity that cannot receive new patients. So wait times lengthen for everyone. Patients who arrived with genuine emergencies wait longer to be seen. Nurses and physicians are stretched across more patients in worse conditions. Research documented in peer-reviewed literature found that patients who board experience missed or delayed treatments, higher complication rates, longer overall hospital stays, and elevated risk of medication errors. The boarding crisis did not emerge from nowhere. It emerged from the same cross-subsidy logic that runs through everything else in this story. Hospitals added elective service lines that generated revenue and occupied beds. They did not add inpatient beds at a corresponding rate because beds are expensive to staff and maintain, and the patients occupying them, admitted through the emergency department, often uninsured or on Medicaid, are frequently undercompensated. The inpatient floor is a less profitable place to grow, so the floor stays full, and the emergency department becomes a waiting room for a hospital that cannot absorb its own patients. There is also the closure wave. Since 2005, 146 rural hospitals in the United States closed or converted away from inpatient services, with more than 80 shutting down completely. A 2025 report from the Chartis Group identified 432 financially vulnerable rural hospitals that remained open but were at risk. The pattern is consistent. Small rural hospitals operate on thin margins. Their patient populations skew toward Medicaid and Medicare, which reimburse below cost. Their volumes are too low to generate the profitable elective surgeries that cross-subsidize losses. When the math stops working, the hospital closes, and with it, the emergency department. What that means in practice is a community that once had an emergency room 8 miles away now has the nearest emergency care 40 miles down a 2-lane highway. For a heart attack, where tissue death begins within minutes, that distance is not inconvenient. It is the difference between a life and a death certificate. Here is where the story turns. By 2019, surprise billing had become politically untenable. Stories of patients receiving bills for thousands of dollars from physicians they had never chosen, for services rendered while they were unconscious, had accumulated to a critical mass. Congress, in a rare display of bipartisan consensus, passed the No Surprises Act, which took effect on January 1, 2022. The law did what its name implied. For emergency services, It banned out-of-network cost sharing. If you went to an in-network emergency department and were treated by an out-of-network physician, you could only be billed at your in-network cost-sharing rate. The insurer and the provider would resolve the payment dispute through an independent dispute resolution process. But that dispute was between them, not between them and you. The balance bill was gone. For Envision Healthcare, the law was catastrophic. The company's business model had been built, in significant part, on the leverage that out-of-network billing provided. When that leverage disappeared, the economics collapsed. On May 15, 2023, Envision filed for Chapter 11 bankruptcy. KKR's initial $3.5 billion equity investment was wiped out. $7 billion in debt was eventually restructured. The private equity giant that had paid $9.9 billion to acquire a physician staffing empire walked away with nothing. It felt, briefly, like accountability. But the structural problems that created Envision, the unfunded mandate, the facility fee, the boarding crisis, the closure wave, did not file for bankruptcy alongside it. The No Surprises Act stopped the balance bill. It did not touch the facility fee. It did not create inpatient bed capacity. It did not reverse rural hospital closures. It did not fund EMTALA. It solved the most visible symptom of a broken pricing system, while leaving the underlying broken pricing system intact. New private equity-backed staffing companies have continued to grow in Envision's absence. The independent dispute resolution process established by the law has been flooded with claims. More than 700,000 disputes filed in just the first year, creating a new bureaucratic bottleneck that has its own costs. The machinery adapted. It always does. Now, to be clear, the American emergency room, for all of this, does something genuinely remarkable. In 2022, Americans made 155 million visits to emergency departments, according to CDC data. At 3 in the morning on a holiday, in a neighborhood with no urgent care clinic, the ER is open. No appointment required. No ability to pay screening at the door. It is the only part of the American healthcare system that is legally required to see you. Emergency medicine physicians are extraordinarily skilled professionals working in conditions of genuine chaos. The nurses who staff those departments are doing some of the hardest work in American healthcare. The argument that a system capable of delivering world-class trauma care in minutes deserves to be funded adequately, sustainably, is not a bad argument. It is a good one. The genuine empirical dispute is over causation. Experts disagree on whether EMTALA itself is the primary driver of ER overcrowding, or whether overcrowding is primarily a supply-side problem. Too few inpatient beds, too few primary care physicians keeping patients out of the ER in the first place. A number of health economists argue that if the US had more robust primary care access and more inpatient capacity, EMTALA's costs would be far more manageable. They may be right. That is a harder problem than passing a law. But here is what the evidence does establish. You built a system on an unfunded mandate and called it a safety net. You allowed the mandate to be monetized through facility fees that carry no national ceiling, through private equity firms that turned your inability to comparison shop in an emergency into a revenue model. You created a boarding crisis by failing to fund the downstream infrastructure that the emergency mandate requires. You closed the rural hospitals that served as the last line of emergency care for tens of millions of Americans, because the math of cross-subsidization only works when there is enough elective volume to do the subsidizing. The villain in this story is not a person. It is not even Envision Healthcare, though Envision's conduct was predatory and documented. The villain is the structure, a mandate without money, a pricing system with no transparency, a cross-subsidization model that functions until it doesn't, and a political consensus that has decided, again and again, that the cost of actually funding emergency care is too high, while quietly accepting that the cost of not funding it gets distributed across every bill, every facility fee, every bankrupt rural hospital, every patient on a gurney in a hallway at 3 a.m. That is what you are paying for when you open the envelope. The facility fee is not a fee for a service. It is a fee for a system that nobody wanted to pay for directly. So instead, it charges you on your way in, on your way out, and in the weeks after, when the bills arrive one by one from people and companies you never chose and never knew were there. Sandra is still in the hallway. The troponin comes back elevated. She will be admitted. She will wait 6 more hours for a bed. And in 3 weeks, she will open an envelope that she does not yet know is coming, from a physician staffing group operating in a hospital she chose because it was the closest one. She will owe $2,200 after insurance. She will not understand why. Now you do.